Hi, my name's Colin Bright, and I decided to do my paper on rheumatoid arthritis. So why did I do it on rheumatoid arthritis? I'm just going to call it RA from now on. Uh, as an avid enthusiast of extreme sports, I think it's important to do research in things that are going to keep people moving and keep people healthy. I also think this is going to be a benefit to the immediate community because there are studies, and I'm going to show you today, that relate low and middle to low income classes with RA diagnosis. And I think it's important really to do studies on people that have it harder than others. All right, so what is RA? Rheumatoid arthritis is an autoimmune disease that causes painful inflammation in the joints. Some identifying symptoms are stiffness in more than one joint, tenderness and swelling, and these are going to be bilateral symptoms that are going to happen on both sides. You're also going to see deformities in chronic RA and signs of synovitis, which is like swelling in the synovial capsules along the joints. So this is the extracellular pathway, all right? Starting at the T cell, it's going to get excited by an antigen. So an antigen is going to attach to a receptor along the membrane. This is going to have it attached to a B cell, and the B cell is going to start producing a protein called a rheumatoid factor. All right, these rheumatoid factors are going to undergo a chemical process known as citrullination. Citrullination is the process of changing argine amino acids to citrulline amino acids. This is done by enzymes known as PADs, and this is going to trigger the release of ACPAs, anti-citrullinated protein antibodies. These are autoantibodies, so these are antibodies that are going to attack healthy cells. All right, so the citrullination of the rheumatoid factors, this is going to activate macrophages to release cytokines. These cytokines are known as TNF and interleukin-1, and we're going to get back to those in a moment. But this will also activate leukocytes, and leukocytes will produce collagenases and metalloproteinases, and all of these factors are going to cause tissue damage within the synovial capsule. So these are the activation of cytokines. Cytokines TNF and IL-1, interleukin-1, these are responsible for a lot of RA symptomatic responses. As you can see, TNF and IL-1, they're going to help to activate the synovial fibroblasts. And the synovial fibroblasts, these are going to release synovial fluid into the joint. The TNF will activate osteoclasts. That'll destroy the cartilage and bone along the joint capsule. And chondrocytes, which will cause more inflammation actually because it's going to add collagen within the joint capsule. All right, so TNF, that's a multifunctional cytokine released by the macrophages. We talked about that. And this is in response to inflammatory events. It also plays a role in a lot of cellular events. We'll also get to that in a second. And interleukin-1 is actually a group of cytokines, and they mediate inflammatory responses to help resist from pathogens. Those synovial fibroblasts, those are going to be interesting because they're actually anti-apoptosis resistant. And that's really what's going to make them kind of tumor-like and make them stick around and build synovial fluid into a place when it's unneeded. It's going to be an inappropriate amount of collagen and synovial fluid in the synovial joint. So now we're getting to the intercellular pathway of RA, the NF-κB pathway. This is going to be activated in the macrophages. So the TNF, that's going to connect with the receptor in the cell membrane along the NF-κB pathway. And that's going to phosphorate IKK. IKK is the kappa kinase. The kappa kinase is a kinase that's going to help phosphorylate IKBA. So this pathway is responsible for a number of cellular responses, including apoptosis, cell growth, and inflammatory responses. Initiated when a TNF ligand connects with a TNF receptor on the macrophage's cell membrane, this will trigger the IKK or kappa kinase, what I was telling you about, to be activated. Now phosphorylation Phosphorylation is when you add a phosphate group to a protein or remove a phosphate group from a protein. You'd use a kinase to add it and a phosphatase to remove it. This will change the conformation or the shape of the protein. So this will either have the protein, when the protein changes its conformation, can either activate it or deactivate it. And this phosphate group will come from ATP or GTP. All right, so back to the cellular pathway. IKK then phosphorylates IKB, the inhibitor of KB kinase. Phosphorylated IKB is important for a number of reasons. For one reason, it carries REL-A and P50, two transcription factors, into the nucleus. It also contains the protein signal sequence, which is required to move the transcription factors through the nuclear envelope, now resulting in the binding and the transcription of inflammatory responses. Now, those anti-apoptosis fibroblasts that we had talked about before, those could arrive from a malfunction along the NF-kB pathway. As you can see on actually the picture, anti-apoptosis, APS, FLP, and BL1, this may cause to too many inflammatory responses happening at once, and this could result in RA symptoms. There is therapeutic treatment. Therapeutic treatment of RA is made possible by blocking the cytokine pathways along the extracellular and intracellular cellular pathways. DMARDs are the most conventional drug for this, disease-modifying anti-rheumatic drugs. They're a group of medications used to treat the underlying causes of inflammation and slow the progression of RA. What this does is they block the cytokines that we had mentioned before. So this includes TNF, IL-1, IL-6, and as you can see in the picture, that's them actually removing TNF out of the synovial fluid and blocking the receptors to activate the intracellular pathways. All right, so globally, RA affects about 1% of the world. However, there is evidence supporting that females are far more impacted than men. There was this study done where they did a clinical evaluation. They saw patients who were diagnosed with RA and they analyzed the gender differences for the American College of Rheumatology. They did 25 countries, 70 research sites, and 6,004 patients. The results were: women had poorer scores than men in all core data set measures. Women had statistically significantly higher mean values compared with men in all other disease activity measures and met DES-28 remission less often than men. DES was used to assess the condition of each patient. DES-28 is a kind of the gold standard of RA measurement. They count 28 different joints and see how many are affected and then compare them amongst each other. So if you have 5.1 affected joints, you're considered high disease activity. If you have 2.6 or less, it's considered remission, and moderate is 3.2, between 3.2 and 5.1. The Quest-RA study found that globally females were far more impacted than men, evaluating that females suffered about half a joint more than men did. This was the mean global average. Evidence suggests that there's possibly a link between estrogen and an increase in cytokine TNF. There was a study done called The Role of Estrogen in Rheumatoid Arthritis Physiopathology. This was done in 2019, where they analyzed estrogen increase with cytokine activity. And these were the results. Estrogens have a direct action upon the immune system through ERA and ER-beta receptors, which have distinct affinity to estrogen concentrations and modifications and have effects upon RA in a dose and receptor-dependent manner, meaning that estrogen actually promoted the production of cytokine TNF and cytokine IL-2 and inflammatory markers that would promote RA symptoms. Another study was done to demonstrate the difference in socioeconomic status and RA diagnosis. The study was called Early Rheumatoid Arthritis in Latin America, Low Socioeconomic Status Related to High Disease. So they evaluated a couple different things. They evaluated the influence of sex, age, marital status, education, medical coverage, socioeconomic status, and ethnicity on 4 different scales: the DES-28, which we talked about, ESR, which is erosion rate, health assessment questionnaire, and disability index. They did this in 14 different counties in Los Angeles with 1,093 patients, 932 which are women, and 160 which are men. The results were patient health assessment questionnaire and disability index scores, pain, and patient and physician global visual index pain, tender joint count, swollen joint count, DES-28, and erosion rate scores were all significantly worse in those with low to middle class socioeconomic status, and those with less education, and those with no insurance versus those with high socioeconomic status. So this is the correlation between being in a low economic group and a high socioeconomic group. The Glatter study concluded that out of 1,059 patients, more than half of RA diagnosed patients were considered low to middle class. The lowest sample size was shown to be the individuals in the medium, high to high end of the scale. The studies suggest that this may be due to the fact that low-income jobs may be more manually intensive, and lower-income individuals may not have access to the same medical or dietary resources as the upper-class group. So as you can see, 618 low to middle socioeconomic status, 618 of them out of the 1,059 fit in that low socioeconomic status group, which is kind of crazy if you think about it. And only 154 were diagnosed in the high economic status group. So there is a correlation between what you do for work, or how much, comfort you get to live, and the diagnosis of arthritis. Although the origin is unknown, the pathogenesis, I believe, lends to different forms of therapeutic intervention. This is important as RA seems to have global impact among women in the lower socioeconomic status. They always tend to be the most impinged upon group of people on this earth. And furthermore, TNF inhibitors seem to display a cancer reduction effect, as tumors also display an anti-apoptosis effect, just like the synovial fibroblasts in RA. So that's good. So it looks like there is hope for the future. Understanding the complications of RA pathology and the related studies requires a knowledge of chemistry, biology, and math. I believe my ability to understand these 3 subjects is due to my education at LaGuardia Community College. I found my classes to be informative and fruitful. The lessons learned through my STEM and fundamental classes will set the groundwork for my future work in life and in